Hi, I'm Divya.
Hi there, my name is Sharifah Noatika binti Manakel.
Hi, my name is Alice.
There, my name is Narfatini.
Hi, I am Maisara.
Hi, I'm Sharon Bhaskaran Kumar.
Hi, my name is Lily Amira.
Hi, my name is Shana.
Hi everyone, my name is Harish.
Hi, my name is Daniel, and we're from group PBL9. For this PBL session, we will be presenting about the different clinical uses of diuretics.
As for the yellow one, we will be looking at the different classes of diuretics. The first class of diuretics we will be looking at is the thiazide diuretics, and the examples include chlorothiazide, trichloromethazide, and hydrochlorothiazide. These drugs act on the epithelial cells in the distal convoluted tubule. Thiazides inhibit sodium chloride reabsorption from the luminal side of epithelial cells in the distal convoluted tubule by blocking the sodium chloride transporter. They bind to the chloride side of the distal tubule, sodium chloride cotransport system, inhibiting its action and causing natriuresis with loss of sodium and chloride ions. The resulting contraction in blood volume stimulates renin secretion, leading to angiotensin formation and aldosterone secretion. This homeostatic mechanism limits the effect of the diuretic on the blood pressure. Now, let us take a look at the clinical uses of thiazide diuretics. It is used in the case of hypertension, where it reduces peripheral vascular resistance, which is the resistance to blood flow in the arteries outside of the heart, leading to reduction of blood pressure by vasodilation. It is also used for treating mild heart failure, but loop diuretics are usually preferred in this case. Thiazides have antihypertensive effect to reduce blood volume and cardiac preload. It acts by reducing preload and relieving stone formation in idiopathic hypercalciuria. Thirdly, it is used to prevent recurrent stone formation in idiopathic hypercalciuria. It decreases the excretion of calcium in the urine by enhancing calcium reabsorption in the renal tubules, particularly in the distal convoluted tubule. This leads to decreased urinary calcium concentration, reducing the likelihood of calcium precipitation and stone formation in the urinary tract. It also decreases renal excretion of sodium. Thiazides are also used to treat nephrogenic diabetic insipidus. It increases renal sodium excretion that causes extracellular volume contraction, leading to lowered glomerular filtration rate and increased proximal tubular sodium and water reabsorption. The second class of diuretics are osmotic diuretics. Its examples include mannitol, as it acts in the plasma and renal tubular fluid. Osmotic diuretics prevents the normal absorption of water by osmotic force. As a result, urine volume increases. The increase in urine flow rate decreases the contact time between fluid and the tubular epithelium, reducing sodium as well as water reabsorption. The resulting natriuresis is of lesser magnitude than the water diuresis, leading to excessive water loss and hypernatremia. Clinically, it is used to treat acutely raised intraocular pressure. In this case, the drug increases the osmotic pressure of the blood plasma. This draws water out of the eye's aqueous humor, reducing the volume of intraocular fluid and lowering intraocular pressure. It is also used in cases of increased intracranial pressure. Osmotic diuretics alter Starling forces so that water leaves cells and reduces intracellular volume. This effect is used to reduce intracranial pressure in neurologic conditions and to reduce intraocular pressure before ophthalmologic procedures. Lastly, osmotic diuretics are also used in prophylaxis and early treatment of acute renal failure. By increasing urine output, osmotic diuretics help flush out potentially nephrotoxic substances and reduce the risk of tubular damage. Osmotic diuretics can also increase renal blood flow by expanding intravascular volume and promoting diuresis.
The next one is loop diuretic. We have four main loop diuretic, which is furosemide, bumetanide, torsemide, and also itacronic acid. So the first one is site of action. Loop diuretic usually act on the thick ascending limb of loop of Henle that located in the renal tubule of the kidney. This segment of nephron play important role in reabsorption of sodium, potassium, and chloride ion from the filtrate. The clinical use of loop diuretic includes edema and also hypertension. As for edema, loop diuretic effective in reducing excess fluid accumulation in conditions such as the heart failure and also the liver cirrhosis. How does loop diuretic help with the edema? Loop diuretic help by increasing urine output and promoting excretion of excess sodium and water from the body. It can help reduce fluid volume in the circulatory system. Excessive fluid retention often leads to the peripheral edema characterized by the swelling in the leg, ankle, and feet. Loop diuretic can also help to alleviate this symptom by reducing the fluid accumulation in the tissue. Edema not only cause discomfort, but it can also cause impaired mobility. Loop diuretic can also help to alleviate these symptoms such as fatigue, swelling, shortness of breath, and also improve overall comfort and function. As for hypertension, loop diuretic can help to lower the blood pressure by reducing the fluid volume in the body, which will decrease the workload on the heart and also improve the circulation. How does loop diuretic help with the hypertension? Loop diuretic will promote excretion of sodium and also water, leading to the decrease in the blood volume. By increasing urinary sodium excretion, it can also reduce the extracellular fluid volume, resulting in the decreased cardiac preload, which is the amount of blood returning to the heart, and ultimately reducing the cardiac output and also blood pressure. Additionally, loop diuretic can also cause vasodilation by reducing sodium reabsorption in the renal tubule, leading to the relaxation of blood vessel and further lowering of the blood pressure. The next one is potassium-sparing diuretic. Potassium-sparing diuretic will exert their effect by interfering with the sodium reabsorption in the kidney that will lead to the increased sodium excretion and water while preserving the potassium. We have two subtypes of potassium-sparing diuretic, which is the first one is aldosterone antagonist, and the second one is the epithelial sodium channel blocker. The first one is aldosterone antagonist. The example will be spironolactone and also eplerenone. The site of action is primarily act on the late distal tubule and collecting duct of the nephron. The mechanism of action is aldosterone is a hormone produced by the adrenal gland, and primary role is to regulate the balance between sodium and potassium ion in the body, particularly kidney. Aldosterone antagonists work by blocking the action of aldosterone on its receptor site in the distal tubule and collecting duct of the kidney. Blocking this effect of aldosterone will result in increased sodium excretion and potassium retention. Spironolactone and eplerenone competitively block the aldosterone receptor in distal tubule and collecting duct, preventing this aldosterone from exerting its effect on the sodium and potassium transport, meaning that they inhibit the reabsorption of sodium and water excretion, thus reduce potassium loss. The next one is epithelium sodium channel blocker. The example will be amiloride and also triamcinolone. The site of action primarily act in the late distal tubule and collecting duct of nephron, same with the aldosterone antagonist. The mechanism of action, This epithelial sodium channel blocker facilitates the reabsorption of sodium from the urine back into the bloodstream. By blocking this channel, epithelial sodium channel blocker will inhibit sodium reabsorption. This inhibition of sodium reabsorption indirectly leads to the decrease of potassium secretion, effectively sparing the potassium. The clinical use of potassium-sparing diuretic includes hypertension, edema, and primary aldosteronism. As for hypertension, this potassium-sparing diuretic usually used as part of combination therapy for the treatment of hypertension. It helps to lower the blood pressure by promoting sodium and water excretion while conserving potassium. The effective of sparing diuretic usually effective and beneficial in patients who are in risk of hypokalemia or those who cannot tolerate other types of diuretic due to the electrolyte imbalance. Edema. Potassium-sparing diuretic used to reduce fluid accumulation in conditions such as the heart failure, liver cirrhosis, and also nephrotic syndrome. They promote diuresis and also helps to alleviate symptoms of edema such as swelling, fatigue, and SOB. They usually used in combination with other diuretics such as the loop diuretic to achieve more significant diuretic effect while minimizing the potassium loss. Last but not least, primary aldosteronism. Potassium sparing. Next one. The last but not least, primary aldosteronism. Potassium-sparing diuretic, particularly aldosterone antagonists like spironolactone and eplerenone, are used in the management of primary aldosteronism, a condition characterized by excessive production of aldosterone by the adrenal gland. They will block the effect of aldosterone. They also reduce the sodium retention and potassium loss associated with the primary aldosteronism. And also, they can also help to normalize the blood pressure and electrolyte balance in the patient with the primary aldosteronism.
Next, we move to carbonic anhydrase inhibitors. The example of the carbonic anhydrase inhibitors are acetazolamide, dichlorpyranamide, and metazolamide. Next, we move to the mechanism of action. It inhibits the carbonic anhydrase enzyme of renal and extrarenal tissue, for instance, eyes, gastric mucosa, CNS, red blood cells, and pancreas. Next, it will reduce the formations of the bicarbonate in the renal tubules and secretory tissues of choroid plexus, where it will reduce the CSF. The ciliary body will reduce the increases in sodium bicarbonate excretion will lead to alkaline diuresis. Meanwhile, decrease in the hydrogen excretions for sodium and hydrogen exchange will lead to acidosis.
Diuresis is subsequently a mild metabolic acidosis, which lead to hyperventilation and thus decreased level of carbon dioxide. As for the therapeutic uses, prophylaxis of mountain sickness where altitude over 3,000 meters. It is also used for epilepsy in childhood. Mild acidosis in the brain which will increase the epileptic threshold. Next, decrease the formation of aqueous humor and CSF. The aqueous humor by the ciliary epithelium, which is located in the eye. And then the cerebrospinal fluid by the choroid plexus. As for the therapeutic uses, open-angle glaucoma is the major indication which has also been used in acute angle closure glaucoma. It also increased the ICP. Next, we move to the side effect. As for the increased sodium excretion, it will cause indirectly increased excretion of lithium ions since they have a similar pathway in the kidney. And then next, alkalinizations of urine. It will interfere with the antiseptic effect of methanamide, and it can reduce the excretion of the quinidine. Next is the side effects of acetazolamide. It can cause fatigue, somnolence, malaise, dyspepsia, substernal burning, hypersensitivity, and blood dyscrasias such as fever, pulmonary depressions, sulfonamide like renal lesions. The alkalinizations of urine is those that interfere with methanamide, divert ammonia of renal origin into systemic circulation. It also can increase the excretions of lithium. By increasing our pH of renal tubular urine, this will reduce the excretions of quinidine and may enhance the effect of quinidine. The side effects of the acidifying salts, ammonium chlorides, are respiratory tract irritations. It can cause allergic reactions, nephrotoxicity, the gastrointestinal disturbance, skin and eye irritations. The therapeutic uses of the demeclocycline, um, it is used to treat water retentions due to inappropriate secretions of ADH. It is most common in patients with edema of cardiac failure or cirrhosis of liver. The side effect of demeclocycline are it can cause the discolorations of tooth, darkened skin color, swollen tongue, vaginal secretions, and itching. And it can cause symptoms like nausea, vomiting, diarrhea, and loss of appetite.
So for the first diuretic is carbonic anhydrase inhibitors. They are typically used in patients with mountain sickness, edema, tuberculosis, or glaucoma. This is because carbonic anhydrase inhibitors reduces the reabsorption of bicarbonate ion, which will cause self-limited diuresis or increase in the urine production. Other than that, it will cause hyperchloremic metabolic acidosis, which will reduce the body pH, and it will also reduce the intraocular pressure, which is the fluid pressure in the eyes.
Now that we know the clinical conditions where carbonic anhydrase inhibitors can be used, let's look at the clinical conditions where loop diuretics can be used. Before that, I'm going to explain a little bit about the effects of loop diuretics. Loop diuretics increase sodium chloride excretion and cause hyperkalemic metabolic alkalosis, also increase calcium and magnesium in the urine. Therefore, it can be used in clinical conditions such as pulmonary edema, peripheral edema, hypertension, hypokalemia, acute renal failure, or renal overdose.
Right, for the next diuretic agents, we have the thiazide. Thiazide is commonly used for the hypertension, mild heart failure, nephrolysis, and also nephrogenic diabetes insipidus. Right, so thiazide is acting for blocking the sodium chloride channel, so they reduce the reabsorption of the sodium chloride ions. This also increases the excretion of the sodium and also the water in the urine. So, due to the diuretic effect, the thiazide also can reduce the volume of blood circulating in the body. This will cause the decrease of blood pressure. Thiazide also will increase the reabsorption of calcium for hypercalciuria patients. Alright, for the next diuretic agent that we have potassium sparing. Potassium sparing can retain the potassium while still promoting the diuresis effect unlike the thiazides. This can be used on aldosteronism patients, hypokalemia, and also post-MI patients. They have the same mechanism like thiazides, that is, blocking the sodium channel to increase the sodium excretion in the urine, but they also prevent the potassium from being excreted. Right, this is important for the patient with hypokalemia, and also by blocking the sodium reabsorption, it also increases the water excretion in the body. So this can help to reduce the water retention from the body.
Okay, so to continue, we have osmotic diuretics. So what is osmotic diuretics? Osmotic diuretics is a type of diuretics. It works by altering the osmotic pressure of the kidney. So by doing this, it would increase the urine output. Osmotic diuretics is usually given to patients with these following clinical condition. Firstly, patients with renal failure due to an increased solid load. Secondly, patients with increased intracranial pressure. And thirdly, individuals with glaucoma. The certain side effects of osmotic diuretics are increased urine outflow, a reduced brain mass or volume, and thirdly, decreased intraocular pressure. Okay, so the next type of diuretics we have is vasopressin antagonist. So vasopressin antagonist is also known as ADH antagonist. So how does it work? It would block the ADH mechanism of your body's homeostasis. So vasopressin antagonist is usually given to patients with hyponatremia. The side effects of vasopressin antagonists are reduced water reabsorption and also increased plasma sodium concentration.
We have discussed the mechanism of action and the uses of diuretics. Let's take a look at the antagonist effect and the interaction with other drugs. So first of all, I want to start with the carbonic anhydrase inhibitor of side effects. We have hyperchromic metabolic acidosis, renal stone, renal potassium wasting, drowsiness or tingling feeling, and hypersensitivity. Hyperchromic metabolic acidosis is predictably result from chronic reduction of body bicarbonate stored by carbonic anhydrase inhibitor and limits the diuretic efficacy of this drug for 2 or 3 days. Renal stone, phosphaturia, and hypocalciuria occur during bicarbonaturia response to inhibitor of carbonic anhydrase. Calcium cells are relatively insoluble at alkaline pH, which means that advantage for renal stone formation are enhanced. Renal potassium wasting due to increased sodium presented to the collecting tubule with bicarbonate ion is partially reabsorbed, increasing the lumen-negative electrical potential index segment and enhancing potassium secretion. For drowsiness and tingling feeling, common following large doses of acetazolamide does lead to electrolyte imbalance such as potassium and bicarbonates. The change of electrolyte level can affect nerve signaling and contribution to the paresthesis and feeling of drowsiness. As for the interaction with the other drugs, for example, is acetazolamide and metenamide. It's basically by increasing the pH of urine. Acetazolamide may prevent the urinary antiseptic effect of the metenamide compounds because metenamides require an acidic urine environment for its conversion for formaldehyde and subsequent antimicrobial action. Next, we have the potassium-sparing diuretic side effects. Generally, the side effects of the potassium-sparing diuretics are hyperkalemia, hyperchromic metabolic acidosis, gynecomastia, acute renal failure, and kidney stones. So, let's take a look by each subtype, shall we? First, we have spironolactone. Spironolactone will give side effect of hyperkalemia, gynecomastia, and drowsiness and confusion. Hyperkalemia is basically due to block the action of aldosterone, which is a hormone that promotes sodium reabsorption and potassium excretion in the kidney, thus the accumulation of potassium in bloodstream leading to hyperkalemia. Spironolactone is an aldosterone antagonist which competes with the androgen for binding sites, particularly at androgen receptor in the tissue. Plus, blocking of the androgen receptor will increase the estrogen, which will have the development of breast tissue in males. Lastly, we have drowsiness and confusion. This happens due to drop of blood pressure caused by this medication, usually happens when they're standing up quickly. Next, we have amiloride. Amiloride side effects are hyperkalemia, decreased blood pressure, headache, fatigue and dizziness, muscle cramp and weakness, and hyperuricemia. For decreased blood pressure is the block of the sodium channel in the kidney, which reduces reabsorption of the sodium, thus more excretion of sodium in urine will cause the decreased volume of fluid in bloodstream, thus reduce the blood pressure. For the muscle cramp and weakness is basically due to electrolyte imbalance because of the retained potassium from excreted out. So the high level of potassium will affect the normal function of muscle, thus lead to muscle weakness and cramps. Hyperuricemia is a reduced excretion of uric acid in urine will lead to the increased concentration of uric acid in the blood. Next, we have trimterene. Trimterene side effects are trimterene nephrolithiasis, acute renal failure, and same as the amiloride. So trimterene nephrolithiasis is a kidney stone. So trimterene is only slightly soluble and may precipitated in urine, so it's going to cause kidney stone. For acute renal failure, trimterene is often used in combination with thiazide diuretic, and it can cause increase the risk of the acute renal failure, hypovolemia, and hypertension, which is going to decrease blood volume or pressure, thus compromise kidney function. Last but not least, the interaction with other drugs. We have potassium sparing with potassium supplement or angiotensin converting enzyme inhibitor, or combination of potassium sparing diuretic will give effect of hyperkalemia. This is mainly due to excess potassium that accumulate in the bloodstream, leading hyperkalemia. If this drug has been combined together, either from increased potassium from intake of supplement or blocking of angiotensin converting enzyme that regulate the blood pressure and fluid imbalance. Next, the interaction between digitalis glycoside and spironolactone. This interaction will decrease clearance of digitalis glycoside mainly due to elevated potassium which impair the excretion of digitalis glycoside, thus it accumulates in the body. That's it from me. Thank you.
For loop diuretic, for the side effects, hyponatremia means electrolyte abnormality caused by excess of total body water than total body sodium. And the next one is the hypokalemia, means low potassium refer to lower than a normal potassium level in the bloodstream. And the next one is the hypocalcemia, means calcium level in blood is low. And the next one is the hypomagnesemia, means have lower than a normal level of magnesium in blood. And the next one is the ototoxicity, means develops hearing or balance problem. And the next one is the hyperglycemia, hyperlipidemia, and also hyperuricemia. Side effect for the thiazide are hyponatremia, dehydration, excessive diuresis, and the next one is the hypokalemic alkalosis that caused by the kidney's response to an extreme lack or loss of potassium. And the last one is the hypochloremic alkalosis, means decline chloride in the body due to prolonged vomiting and sweating. So for now, I'll be explaining about drug interaction between loop diuretics and also ototoxic drug. For the loop diuretics, for example, furosemide, it can enhance the toxicity of ototoxic drugs, for example, like aminoglycoside. It's leading to hearing loss or balance issue. Careful monitoring and dose adjustment are necessary to prevent adverse effects. So now I'll be explaining about drug interaction between thiazide diuretics and lithium. Thiazide diuretics can reduce lithium excretion that leading to increased lithium level and toxicity. Regular monitoring of lithium level and adjustment in dosage are required when these drugs are used concomitantly. We explain about thiazide diuretics and oral hypoglycemic agents. Thiazide diuretics can impair glucose tolerance, potentially requiring adjustment in the dosage or regimen of oral hypoglycemic agents to maintain glycemic control.
Thank you, my Sarah. Now I'll be talking about unwanted effects and interaction with other drugs for osmotic diuretics and vasopressin ADH antagonists.
First and foremost, we have osmotic diuretics, for example, mannitol, urea, and glycerin. So I will explain all of it one by one. Let's get into mannitol. Some of the unwanted effects of mannitol are such as expansion of extracellular fluid, ECF. Mannitol is an osmotic diuretic that works by drawing water into the kidney and increasing urine production. This can lead to expansion of extracellular fluid volume, which can be hazardous in patients with heart failure and pulmonary congestion because it can exacerbate fluid overload and worsen their condition. Next are headache, nausea, and vomiting. These symptoms can occur due to hyponatremia, which is caused by the extraction of water from the body cell into the bloodstream due to mannitol's osmotic effect. Other than that, dehydration can be one of the unwanted effects also. Paradoxically, despite being a diuretic, mannitol can lead to dehydration due to the loss of water from the body through increased urination. Next, we have urea. Some of the unwanted effects of urea are thrombosis. Urea, when used intravenously, can increase the risk of thrombosis, which is the formation of blood clots within blood vessels. This can be a serious complication. Additionally, pain if extravasation. Extravasation refers to the leakage of a drug from the blood vessel into the surrounding tissue. Urea can cause pain if this occurs. Next, glycerin. The unwanted effects are such as metabolism and hyperglycemia. Glycerin can be metabolized in the body, potentially leading to an increase in blood glucose level, which is hyperglycemia. Furthermore, glycosuria, which is the elevated blood glucose levels, can lead to the excretion of glucose in the urine. Hence, some of the interaction with other drugs are interaction with lithium. Osmotic diuretics can increase renal clearance of lithium, leading to decreased lithium levels in the blood and potentially reducing its therapeutic efficacy. Also, interaction with digoxin. Osmotic diuretic can cause electrolyte imbalance, particularly hypokalemia, low potassium levels. Hypokalemia can increase the risk of digoxin toxicity. Low potassium levels can enhance the effects of digoxin on cardiac muscle, leading to increased risk of arrhythmia and other cardiac complications. Secondly, we have vasopressin ADH antagonist, under which we have conivaptan and tolivaptan. Same goes here. I will explain all of it one by one. Let's get into vasopressin ADH antagonist. Some of the unwanted effects of conivaptan are such as hypertension. Vasopressin plays a crucial role in regulating blood pressure by constricting blood vessels, particularly in situations where blood pressure drops. Blocking the action of vasopressin with antagonists can lead to vasodilation, which is the widening of the blood vessels and subsequent hypertension. Besides that, nausea. Nausea can occur as a side effect of vasopressin antagonists due to their effects on the gastrointestinal system. It is known that alteration in fluid balance and electrolyte level can contribute to gastrointestinal disturbance, including nausea. Additionally, the stress on the body caused by dehydration resulting from increased urine output can also trigger nausea in some individuals. Other than that, constipation. Dehydration caused by increased urine output can lead to decreased water content in the gastrointestinal tract, resulting in harder stools and difficulty passing them, thus leading to constipation. Next, we have tolivaptan. The unwanted effects are such as dry mouth and thirst, polydipsia. Blocking the action of vasopressin with antagonists result in decreased water reabsorption in the kidneys, leading to increased urine output. This increased urine production can cause dehydration and trigger thirst as the body tries to replenish lost fluids. Dry mouth can occur as the result of decreased saliva production due to dehydration. Next, constipation. Dehydration caused by increased urine output can lead to decreased water content in the gastrointestinal tract, resulting in harder stools and difficulty passing them, thus leading to constipation. Other than that, weakness. Dehydration, which can occur due to increased urine output, can lead to electrolyte imbalances and decreased blood volume. This can contribute to feelings of weakness and fatigue. In addition, urinary frequency. Blocking the action of vasopressin results in increased urine production, leading to more frequent urination. Lastly, some of the interaction with other drugs are interaction with carbamazepine. The risk or severity of water intoxication can be increased when carbamazepine is combined with vasopressin. Then interaction with dopamine. Vasopressin may increase the hypertensive activities of dopamine. Also interaction with enalapril. Enalapril may increase the fluid retaining and vasopressor activities of vasopressin. That's all from me. Thank you. Terima kasih. Sheshe Nandri.